right? They are benign. They do not grow, they do not spread. Others are malignant, where they do aggressively grow and spread. Right? So we do want to make sure we are able to group these tumors into benign versus malignant. Now, X-ray is not the modality of choice for imaging tumors. Okay, X-ray is not a great modality for tumors. If you do want to see tumors, CT, MRI, nuclear medicine, those are going to be better to visualize tumors. Okay, X-ray, you may have like an incidental finding, you may happen to see the tumor on the X-ray, but it's not great for trying to figure out where it is, where the border is, how far it's spread. Once again, just as a review, metastasis, remember this is the spread of cancer cells. So the cancer starts in one location and it spreads somewhere else. That is metastasis. Metastasis is something that is a trait of malignant tumors, right? Not benign. Benign tumors don't spread, they don't grow like that. But malignant tumors, those are the ones which will have metastasis. And this is the most common source of malignant bone tumors. So it's not that the tumor started in the bone, but it's that a cancer cell from somewhere else made it to the bone or the bone marrow and began to grow that way. So, first one we have here is multiple myeloma. So this is the most common primary cancerous bone tumor. So what we mean by this is that this actually does start in the bone. Okay. This is most common in people that are around middle age, so like 40 to 70 years old. And it comes from the bone marrow or the plasma cells of the bone marrow. Multiple myeloma is highly malignant and is often fatal.
Is this blood cancer, sir?
No.
It's not.
So, well, that's the fact. What do we mean by blood cancer?
Remember when you say the blood cancer, it's also with the bone marrow, right, sir?
So yes, the bone marrow is involved in the creation of new blood cells. Right? So yes, with multiple myeloma, you will see an impact to the ability to properly produce blood cells. Now, if you take a look at the look of this bone, you'll see that there's like these dark spots, right? So the bone appears to be kind of like punched out. And in long bones, you may see endosteel scalloping, right? Not endosteel scalloping, but endosteel scalloping. So what that means is that you've got these indents, right? Kind of like it's eating into the cortex of the bone here. So some other examples of multiple myeloma. Right, if you take a look here, right, you see these kind of like holes, like you punched out parts of the skull. Right. Over here, right, once again, you can kind of see that, and you can also see that the cortex looks kind of rough because of that endosteel scalloping. So oftentimes, when a person does have a cancer like this, one of the things we will do is a skeletal bone survey. Has anyone seen a bone survey in clinic yet? Oh, you have, Carla. How was it?
A lot of pictures.
It was long, wasn't it? A lot of x-rays, right? A lot of pictures. Do you remember about how many pictures you ended up taking?
17, 18.
Right. Because what kind of pictures do? You do pictures of the axial skeleton, right? So you're going to do head, you're going to do the entire spine, you're going to do chest, you're going to do skull, you're going to do extremities. So you are going to end up doing a lot of pictures.
So what was the numbers there?
Don't write that down. Don't write it down. It's not important. Yes, Jay.
So, to find multiple myeloma, X-rays are useful, or it's just a modality that we can or it's something that
Right.
shows up?
So X-rays are useful. You can use it to show multiple myeloma, but it's not going to be your gold standard for imaging, right? Because if you're trying to see, okay, how far in the bone has this multiple myeloma spread, X-rays are not going to be accurate enough for a doctor. Like you would want something like CT or something like MRI. Okay. Next one we have here is osteogenic sarcoma. Okay, so osteo, what is that? Bone. Genic,
Build.
great. So it starts in the bone, right? Osteogenic. Okay, and then sarcoma, right? So we know that this is a malignant tumor. Okay, another name for this is just osteosarcoma, right? Just take out the genic. We'll just call this osteosarcoma.
Did you say genic means starting, sir?
Yes. So, second most common primary cancer is bone tumor, right? Multiple myeloma is most common. This is second most common. All right, multiple myeloma we saw affected people in their middle age. Here, this is going to most commonly affect people that are younger, right? 10 to 20 years old. May also occur in older people with Paget disease. If we take a look here, right? This is not an X-ray. Right? This does not look like an X-ray, does it?
It's an MRI.
No,
It's a
this
CT.
is going to be a CT. Right? But here you do see that cancer. So what does this actually look like on an X-ray? Well, it looks something like this. Right? So you've got right, the growth kind of right there.
So it can be seen by X-ray, but should be seen by CT. That's what you're saying, sir.
Better image for CT or MRI. Yes, Jay.
On the test, would you, if you're asking like what pathology or what pathology is this? Would you say this as one of the answer choices and also the cortex cancer? I forgot the name of it. Or would that all like be too similar to differentiate? Because on the right image, it looks like it's coming from inside as well as like protruding out. So I'm just trying
So if I do give you an image like this, I will make sure to include other information that will help you narrow down
Okay.
the correct answer. Right, once again, I'm not going to ask you to diagnose, right, unless it's something very, very obvious, like a Boxer's fracture or a Coley's fracture, right, or a Smith fracture. Or some other very obvious fracture where it's like, this is the anatomy, you really only learned one fracture dealing with this anatomy, it has to be that fracture, right? So if I show you a picture and there's a fracture on the first metacarpal, that can only be one fracture, right? That would be for distal phalanx. First metacarpal, we've only discussed one fracture for the first metacarpal. Bennett fracture, very good, right? The one that cuts across here. So something like that would be fair game because you really only learned one. Something like this where it's cancer, where it's kind of uncertain, I would definitely give you more information. All right. Here we have Ewing sarcoma. Okay, this is a very common bone tumor in children. Okay, yes, it can affect adults, but you mostly see this in children. This arises from the bone marrow, once again, and it creates an onion peel appearance on radiographs. So what that means is that, you know how the onion peels have layers, right? Sometimes the layers can like pop up like this. So, do you see this here?
Yeah.
This line, how it kind of like peels away from the bone. That's what we mean by that onion peel appearance. So, some other examples here. Right? You see these layers, kind of like it's peeling away. Over here, let's see, where is it? Anyone see it? Oh, I think this is just a zoomed in image of this. It's kind of hard to see here, but when we zoom in, you can see that peeling. Yes?
Do the bones become weak, like, because it's peeling?
Did the bones become weak? It's a good question. I assume so, but I can't say for certain.
But say if the top is caving off, it has to become deep. Right?
Don't say it has to be,
Not
right?
necessarily.
Not necessarily. But I assume that it would be weaker. Right? Oh. Blowing to the floor. Okay. Alright. Chondrosarcoma. Okay, remember, chondro deals with cartilage. So, not quite the bone, but we're dealing with cartilage instead. If you take a look here, you can see that chondrosarcoma creates these really dense calcifications. Can you really see the anatomy around here? Any idea where this chondrosarcoma is growing?
If you
The
look
scalpel
at the
humeral
TV, you
joint.
can see it a little bit better.
Oh, yeah, the TV might show it a bit better.
Oh, the humerus.
The deeds
Yes.
and
So this is growing at the humerus, right? You can kind of see the chest and the ribs here, right? You can see the humerus here, right? And here is our chondrosarcoma. Okay.
It's not at the joint or like surrounding.
So this is actually not at the joint. The elbow, the shoulder joint would be somewhere up here.
Okay.
So Mr. Phung,
Oh,
Yes.
my question on this one,
Mhm.
why does it look like is the patient wide or something, like on their arm? Why is it so wide? You know what I'm saying?
So that's just how it grew. So I assume that the patient's skin would look kind of like,
Look like this? Oh
Yeah.
my gosh.
Mm.
I assume it would look kind of deformed. It would look very weird. This is probably a very extreme case. It's not usually gonna go this crazy, I don't think.
Is there a more realistic image then?
Yes, so, so let's see here, here's it. So I believe it's gonna be these calcifications here that we're looking at.
What about
It's not that protrude.
Which one? Which protrusion?
The protrusion between the. No, never mind. I lost it.
Okay. No, I believe it's gonna be this right here. Yeah, and this dense area right here.
What about on the lateral? Like how wide it is? Or is that just technique?
Which one are you pointing at?
To the left picture?
On the left picture?
Yeah.
Oh, you're talking about like
On
up top by the
lateral
femur?
side, Yeah.
No, I think that's just technique.
Technique.
I had this problem this week.
So those four we just talked about, right? Multiple myeloma, osteosarcoma, chondrosarcoma, and Ewing sarcoma, right? These four are malignant tumors. On the other hand, we have some benign tumors. Okay, so these are not going to metastasize, these are not going to spread. Here we have enchondroma. Once again, we see chondro, right? So that tells us this is once again dealing with the cartilage. This gives us well-defined radiolucent tumors. Why is this? I wonder if I can improve the contrast here. Give me one moment.
So is the cancer there underneath the fifth digit or metacarpal?
Sorry, one second. Let's see.
You're getting
Oh, that's cool.
contrast to the image
Is that better?
here.
Yeah, 100.
It was better.
100 was better.
No, we put it.
Yeah, now that's worse. Now that's worse.
Which one is it?
The
I
right.
think if we turn off the light, it looks better.
Yeah, it does look good.
Still looks a lot better on the TV screen though.
Oh, it looks
See the
like
soft
it looks
tissue
better.
right there.
And we keep the lights off because we help with like.
All right.
Sleep.
Yeah, we can-
Sleepy.
Yeah, I like it. Who said sleepy? A fire.
What about color saturation?
Oh, there's tint on it.
Who said sleepy? I don't know. That was John and Esther.
No, that was J with the J.
What?
Guys, if you look at the TVs,
Yeah,
look at the
Jordan.
TVs, where do you think the pathology is?
Yeah, so look at the TV. It's gonna be a lot easier.
Yeah.
Oh no, it's just in the carpet. Yeah.
It's the.
So where do you think you see it?
It's in the
PIP.
carpet.
She's pointing at it.
No, it's
Rachel's
near
pointing
the
at it.
middle.
Yeah, the
PIP.
Very good. The base, or sorry, what is that location called?
You're gonna say it, Mr. Phung?
Yeah, the leaf said
There
base.
you go.
The proximal,
You're making sure you,
All right.
you're
Third
making
PIP.
sure you know it.
Third
Yeah.
PIP.
Good. So base of that third proximal phallus.
usually whenever we do our test, we usually.
Do you have a pencil I could have?
Oh, on the screen.
Do you have a pencil I could have?
So yeah, right. So it's a bit hard to see on this one. Check your TVs, right? But you can see this lucency, right? It's radiolucent, dark. So this does lead to a thin cortex. So the bone is going to be weaker. So it is going to be more at risk for fracture. Once again, this is the same patient. So you just look right here, right?
Sounds like it's one
Looking at that, over here, right, you see this radiolucent area right there. And finally, we have osteochondroma. So
Ooh.
this one,
It's a kidney.
well, right there.
Benign?
This is benign, yes.
Did you say
So this will not
chondroma?
spread to like other parts of the body. It won't metastasize, but it does create this growth of the bone.
So did you say chondroma means malignant?
No,
The
so
way
chondroma
evolved.
was cartilage.
He's straight up
Oma
evolved.
meant
Oma
malignant?
is tumor.
So I wrote it here, you said something like, or something like with the oma, their chondromas are normally
Your
malignant.
sarcomas are malignant.
Sarcomas.
Yes.
So that
What
one
is SARC?
on the test,
Also,
like what
see,
is
I
it?
cut it out.
Yeah, that's fine.
So this one, yeah, this one I could probably
What is
answer.
what is SARC?
He got so
Because
happy.
this is so interesting, right? So it comes from the outer cortex. It grows parallel to the bone, away from the joint, right? So it grows out this way, and it grows along the same direction as the bone, but away from the joint. Which is just going to keep growing this way, more proximal
What is
to
the
the body.
cartilage?
And
Now
guys,
you
make
know it's
sure
a
you,
bone.
even though he might not even show that image, he might just ask like the definition of what the pathology is, and you have to know what goes with what. Like basically, he said one was the primary, how was primary, we didn't know those, the difference between primary and secondary, like that type of stuff. I'm trying to get you.
Will it come out of the skin? I don't think it'll come out of the skin. No.
Why don't they just shave it off?
I assume they would be able to if they wanted to surgically remove it. So most common in the knee, as we can see here. You can also see this in the pelvis or in the scapula. Yes.
Would we, because it's attached, we wouldn't count that as like a sesamoid or anything like that?
No, that's not a this is abnormal. So another it is a tumor. Okay, another
I was just.
exostosis, right?
Just joking.
Ostosis, right? All right. So that brings us to the shoulder girdle, which has its own unique set of pathologies as well.
Why did, what sax sounds familiar? What's that from?
They're like, this should
No
have
sex?
His, that sounds familiar.
This should have
What,
been another chunk.
Yeah.
what,
Oh my God.
Mr. Fung, we were
Yes.
just complaining, and we were doing lower extremity, and we didn't even learn that yet. And it was like all mixed in.
That's true, that's true. In yours, I had mixed upper and lower extremities
I
together.
know. So we
Or
didn't
your
even
jaw.
know. We didn't even know what the lower extremity was.
All right, well, it's okay. It's okay.
Y'all-
We'll get through this together.
Oh, did you?
We'll get through this together.
What?
So,
What?
a lot of these actually aren't too bad. For example, do you see these underlined ones?
This is fun.
We've already covered these underlined ones, haven't we? Right, so don't need to worry about those. Because we've already studied them. So,
Just
Who won?
we have AC joint separation. We just learned about the AC joints today, didn't we? Thanks to Ms. Hawkins. So, where are the AC joints located?
Between what?
Clavicle and
acromion.
acromion of the scapula, right? So these are your AC joints right up here. So AC joint separation is just a subluxation or a dislocation of those AC joints, right? So if something happens, trauma to the upper shoulder, okay, so the ligament here is compromised, and now the clavicle is free to move away from the scapula. Right? Very common for athletic shoulder injuries.
Is this joint the most common like site of the injury to the clavicle, or is it just like
Most common site of injury to the clavicle. That I am not sure about.
is like we said the scaphoid was the most fractured, carpal?
Right. That I don't know. I would need to do some more research on that.
Okay.
Okay, so there are 6 categories. Do you need to know all 6 categories? No. That's beyond the scope of this course, right? But just know that there are various types of AC joint separations, just depending on which ligament was injured. Right, so if you see Rockwood, right, you need to know Rockwood classifications is about AC joints,
And the athletic shoulder injuries.
athletic shoulder injuries. All right. We've also got just pure AC joint dislocations. Right? In this case, the clavicle just goes pop, usually it pops straight up. In this case, usually because of a fall, and more common in children than adults. So what kind of x-rays do we do for AC joint dislocations and AC joint separations? Well, we do AC joint x-rays. We have actual x-rays that are specific to the AC joints. So erect AC joints with and without weights for both of these. And you will get a chance to see that next week in lab. You will see erect AC joints with and without weights. All right, now we get to some of the fun ones. Bankart lesion. So, this is an injury to the inferior aspect of the glenoid labrum.
Repeat that again, please.
All right, that's a lot of fancy medical words there, right? Anterior, what does that mean?
The front.
The front. Inferior, what does that mean?
Below.
Lower.
Good. So if you have your glenoid, right? If you think of your glenoid like this roll of tape, right? It's kind of like this cup here. We are gonna be looking at an injury towards the front, bottom of the glenoid. That's all this is saying. Right? Antero-inferior aspect of glenoid labrum, just the front, bottom of the glenoid. Yes.
And when you
What's labrum?
sorry, when you say it's to the anterior and inferior aspect, you mean that the force is coming from behind to push it forward, or?
Not necessarily. So this is just anything that can damage that area of the glenoid. And as you'll see, actually the most common reason the glenoid gets damaged is from movement of the shoulder in an unnatural manner. So if the shoulder is dislocated, the most common type of shoulder dislocation is anterior. Like the shoulder normally pops forward when it comes out of the socket. So you've got the shoulder sitting inside this glenoid. Shoulder pops out, try and pop it back in. Shoulder pops out, try and pop it back in.
Yeah.
What part of the glenoid does this head of the shoulder keep passing by? That's right, it keeps passing by this inferior part of the glenoid. So that is why it gets injured. That's one of the more common reasons why it could get injured.
What do you mean by lateral?
It's the tissue surrounding the glenoid. So, what happens then is we have our ligament here, which is connected to the edge of the glenoid, and as this happens, the stress on that ligament pulls at the glenoid, and it can pull off a fragment of the bone. And what do we call a fracture where we pull off a fragment of the bone?
Open fracture.
Oh,
Avulsion.
yes.
So remember, avulsion fractures are where we pull and part of the bone comes with it. Another example we saw earlier was the baseball finger, the mallet finger, right? You have the distal phalanx, the ligament here pulls on the distal phalanx, and part of the distal phalanx comes off with it. Avulsion fracture.
So, if I said the Bankart lesion is often caused by a posterior shoulder dislocation, what would that be, true or false?
False.
False, okay, why?
Anterior.
Very good. Now, if we take a look at what kind of x-rays we would do for this, right? We would have our normal shoulder here, but also we have this scapular Y, and we also have the Gracie method. So scapular Y, you actually saw that in Ms. Hawkins' PowerPoint earlier, right? Remember the Y shape of that scapula? Okay. So
Why do we do that view?
To view the crest, right?
Is it for this?
Dislocation.
Yes.
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 Good. Scapular Y, great view for dislocation because it's basically your lateral view of the shoulder. So you can see if the dislocation goes anterior or posterior. Gracie, that is looking at your glenoid in profile. Right? So Gracie is great for looking at the glenoid in profile so you can see if there is injury. So if you take a look here, this is a normal shoulder x-ray. This is a normal AP internal rotation shoulder. Do you see anything wrong here? Space where? Here? Here? Or which way do I move my finger?
Down.
Right there? That's the AC joint. Nothing wrong with the AC joint on the Bankart
The
lesion.
Yeah.
scapula femoral. Exactly.
Go to your, yeah, it's not supposed to go that far.
No, that little bump that you
Glenoid,
just
right?
passed.
This?
Yeah.
This is your lesser
We didn't get into that. those
The
positions,
tubercle?
tubercle. Yes. This is your lesser tubercle. This is your greater tubercle. So this is okay. This is normal. You're supposed to see lesser tubercle here on this view of the X-ray.
I'm talking about inside the glenoid.
Do you,
Like it's too much inside that joint.
Too much inside the
You
joint.
get what I'm saying? Like, I don't know.
She thinks that there's supposed
So,
to be a gap.
if
Yeah.
you look really, really carefully,
it's up here.
right next to this glenoid, do you see this white line here?
Oh, yes.
Now look over here on this view.
Yeah.
Do you see this?
Yeah.
How it came off? That's what we're looking for, right? We part the glenoid, the anterior, inferior part pulled off, right? That is our Bankart lesion. So this is our Gracie view. Notice that the glenoid is in profile, right? You can see it perfectly. Here, the glenoid is oblique, so you can't quite see it as nicely.
So the concavity from the glenoid is from the piece that's missing?
So this concavity
No,
here,
no, no. The one that's on the bottom.
oh, down here,
Up?
yeah.
Yeah, that, like right
Oh,
above
here?
your laser for a sec. Nah, go down a little bit to your left. Right there. There's like a depression.
So this
Yeah.
thing right here?
Yeah, is that where it came out of?
Yes, that is your Bankart lesion. Right. Now, associated with this Bankart lesion is the Hill-Sachs defect. Because I want you to imagine, if there was enough stress to cause damage to this part of the glenoid from the humeral head popping out, right, like this, what other bone do you think will be affected aside from just the glenoid of the scapula? The humerus, right? Because the humerus is also getting stressed when it moves back and forth like this, when it dislocates. So the Hill-Sachs defect deals with the humerus. This image we are looking at from the back, right? We're looking at the back of the scapula, right? Here's that spine, right? Supra, infra, right? And here you see that we dislocated, the humerus went forwards, and now it gets damaged along the back. So this is a compression fracture of the posterior, right, the back part of the humerus, and the lateral, the side part of the humeral head, right? Not the medial, but the lateral part of the head. And this comes from impaction, right? It hit that anterior glenoid rim,
Which
right,
is on the back?
associated with the Bankart lesion. Sorry, what was that, Jay?
I was saying the anterior glenoid rim. Where is that located?
So it's going to be this part right here, the front of the glenoid.
Okay.
So if I say the Hill-Sachs defect deals with the posterior dislocation of the humeral head, is that true or false?
Would they deal with after reducing that or whatever? Would they just give them a cortisone shot and have them on their way, or?
That's a great question. That I do not know.
Because it looks like it would. It looks like it would go against the actual like bone and the joint like space. I'd imagine they do some fluid.
So that's a good question. I'm actually not sure about the treatment of a lot of things.
But I'll stop asking.
It's okay. If I know, I'll definitely let you know. Fortunately, it's treatment is kind of like outside the scope of what we're talking about. But I'm glad that you are curious.
It helps me associate like different pathologies to like know how to treat it or what to do.
Okay, so over here we have another Gracie shot of that shoulder. Okay. So we're looking for damage to the posterior lateral aspect here of the humeral head. Okay. But it's not very obvious here, right? It's not very easy to see. Okay. In fact, looking at this, it's hard to tell that there's even a dislocation, right? But you come over here to this image. This image is an axial or an axillary view of the shoulder. This is like the Lawrence method, which you will learn. So now, do you see the glenoid right here? And do you see how the humerus has shifted forwards? Okay, it's shifted forwards, so it's been displaced interiorly, and the glenoid here is putting pressure on this posterior aspect of the humeral head.
Just for fun, what else is in that X-ray to the right that you guys see?
On the right?
You can see a finger.
Patient's right.
Patient's right? No. Patient's anterior? Patient's posterior? Which one are you looking at?
I'm talking about the hand.
The hand? Okay, yes,
Yeah.
we do have a hand.
I thought you were
You see the
asking them.
finger.
Oh,
So are
okay.
they resting like this or?
So they're holding the cassette like this.
Okay.
They're holding it, yep.
Making them work, huh?
I mean,
Well, this
Are
could be
you gonna
something
stand in the
visual.
picture here?
Could be something
Dude,
that they have to
Can you
hold.
show us one more
Oh,
time?
yeah.
so basically, patient is holding the cassette like this while laying on their back.
Oh.
Okay.
Isn't there an alternative, like going it, like when they lean this way? I don't know the name
Yes.
of it.
Yeah, I don't know if there's a If there's a name for it, I'll have to double check, but yes, you can do it the opposite way where you lean over.
So you wouldn't have the patient just like rest their arm on a super high table or something?
So, like Aaliyah said, that is an alternative method. You could try and have them rest their arm on a high table,
And then
lean
shoot
them
like
over to
this.
IR, and shoot through the top of the shoulder instead of
Instead of
through the arm.
Oh, okay, okay.
Yes, but you'll learn all about that. Do you see this long bone here? Any ideas what this long bone is?
That's the clavicle, isn't
That's the clavicle, great. So then what do you think this hook-like bone is?
Chromium.
Yes, this is what the chromium looks like from either above or below. And then what about this bone sticking forwards here? See it louder? Coracoid, very good.
It's not cornoid.
it? Corona is the,
Y'all better not miss that, cause he gonna be like, what?
That's right. Don't make Mr. Donahue mad at the Hawkins there. All right, next up, we have idiopathic chronic adhesive capsulitis. So idiopathic means unknown cause. We're not quite sure why this happens. Okay, chronic, right? So not short term, right? This isn't something that's acute. Adhesive capsulitis. Okay, so this is talking about the capsule or the joint space of the shoulder. And adhesive means that it's sticking. In other words, this is commonly known as frozen shoulder. Okay. Where suddenly there's a very limited range of motion here in the shoulder. The shoulder is not moving the way the patient would normally be able to. So, like the name suggests, we're not quite sure why this happens, or we're not quite sure what sets this off. But what happens is that the joint capsule here becomes inflamed, right? Because it is inflamed, now that inflammation keeps the joint from properly moving. So, here, just kind of like be familiar with the name, right? Be familiar with what it is, and also be familiar with this abbreviation, ROM. Range of motion. This is a great abbreviation because when I am doing patients and patients aren't able to move the way I'd like, I just go in and I document patient with limited ROM. Right? Just for all my experience, like, they can't do that? All right, fine. Patient with limited ROM. That's why the image looks the way it does. All right. Don't actually do try to work with your patient, but ROM is a great abbreviation to know. All right. Impingement syndrome. So, impingement, basically, you've got this pressure, you've got this pinching, right, on something. In this case, pinching on like a nerve or pinching on a tendon. So, we've got some sort of pinching of the shoulder here, usually when there is abduction of the arm. Which direction is abduction? Right, away, right? So try to move the arm away. It's like, right? There's a pinching right there. So for this one, we've got a unique method. We have the near method, which you eventually talk about with Mr. Donahue. So if you take a look over here, what is potentially causing impingement of the nerves running through this gap in the Y? Do you see the weird looking things?
Oh, the blunters.
Do you see that? That's a lot longer than it should be, right? So it's sticking into that cavity, and so it would be causing that impingement. So it looks like they believe this was some sort of ossification, some sort of hardening or calcification that occurred here, and now it's impinging on the nerves passing through here.
So that's not a bone that's already.
That is not natural.
Okay,
Normally, we
okay.
do not have something here. If we go back to,
Would that be like a bone spur?
yeah, kind of like a bone spur. Let's see, do I have a wide view from here? I thought I had a wide view earlier.
Yeah, you
No?
did. Guess not.
Okay, that's not.
It's probably the beginning.
Yeah, probably. Alright, let's not worry too much about
So
that.
it said the coracoidial, yeah, the acromial
Mm-hmm.
ligament ossified. So that would cause a bone spur or something adjacent. So if a ligament
Mhm.
just like completely ossifies to the point where it's like sort of undistinguishable from the bone, it would be considered a bone spur. Or
no, so they are different. Right, a bone spur is just an extra growth of bone out of the cortex. This is the hardening of something that was already there.
okay.
All right, rotator cuff injury. So, if you take a look here, what do we use for rotator cuff injuries?
MRI or sonography.
Right, MRI or sonography. Why? Because this deals with soft tissues. Really hard to see soft tissue injuries on X-ray. Okay. It does involve all these muscles here in the shoulder.